Hey everyone, thanks for coming. On behalf of Captain Scott Goldstein, welcome to the Pikesville Volunteer Fire Department Training Space. For those who I haven't met and for the online community, my name's Sean Barinholtz. I'm adult anesthesia and critical care physician at Hopkins. I'm a member here at Pikesville and I have the honor of serving as CAR 609 in the medical director's office. On behalf of the medical director's office, welcome. I think Dr. Wittberg, one of the deputy medical directors, is going to be with us tonight. On behalf of the EMS office, for sure, Director Schenning, Captain Willits, Captain Stewart, thank you as always for your support. A huge shout out to Ashley and Hunter for creating and managing this live stream that allows people throughout the county and throughout the state to participate. We heard from a company that they're going to do a company training, so they're going to have a bunch of people at Liberty Road, for example, that are going to be able to watch this as a team together, right? What a great company exercise to be able to watch online and to be able to get CEUs. So I'm very thankful for you guys for creating that capacity to do live stream. So tonight we have some repeat guests, Eve Koehler and Linda Toral. Toral. Thank you as always for coming. Eve is a stroke program coordinator at Northwest Hospital. Her background includes stroke research at the University of Maryland, 5 years of caring for stroke patients on a stroke unit, and her current role for 1.5 years. Linda Toral is a stroke certified registered nurse and certified neuroscience registered nurse with over 30 years experience in nursing. She graduated from the University of Delaware, where she volunteered on the student ambulance, City of Newark ambulance, and in the Newark Emergency room. She has been with Sinai Hospital since 2000, holding various positions to include outpatient clinical manager, stroke unit case manager, stroke program coordinator, and her current role of manager of the NeuroRescue Network at LifeBridgehealth. She's participated as an invited speaker in stroke research review courses and at Maryland Comprehensive Stroke Conferences. She's also provided education to Baltimore City, Baltimore County EMS providers in coordinating training for the Baltimore City EMS pilot that just got rolled out in Baltimore. So I really look forward to gaining some clarity on that pilot, as well as the posterior cerebellar assessment, which is new to us in the field as well. So first of all, to bring snacks, really? That's very generous. Thank you so much.
If we feed them, they will come.
I love it. And thank you for coming again and being a repeat guest and, as always, sharing your expertise, and welcome.
Absolutely. Thank you. Our pleasure. Welcome, everybody. Thank you for joining us today. I want this to be very informal, so please, if you have a question, shout out, stop us. As I understand it, there are people at all different levels of training, so I do have a little bit of background, statistics. I'll kind of work through the general information about stroke rather quickly in the beginning so that we can get to the more detailed information about the posterior or cerebellar assessment. We have a lot of case studies because we know that's a really good way to teach, and we also know that you like to hear feedback. These are all Baltimore County patients. So with that, I will start with...
one or two are Carroll County.
Okay. Well, true. That's true. But they came to you. Yeah, right. Most of Baltimore County, right. To start, these are our objectives. Not going to read them to you, but you'll have a copy of this, and I know there's something online. Our disclosures, we have no financial disclosures, but I will say that one of us has been doing this for a really long time. You can see the group rocking the 80s hairdo over here, some before many of you were born, so okay. So to start, Eve?
Okay, so I'm going to start out with a case study. Okay, so we'll call this patient number 1 ET. So this is from September 5th of 2019. At 1550, Baltimore County EMS were dispatched for a stroke. They arrived on scene 9 minutes later and found a 75-year-old male who was watching football, but he tried to stand up and then collapsed. He was unable to move his right side, he couldn't talk, and he was not responding to pain or voice. EMS assessment was that his GCS was 6 and his blood glucose was 160. They found he had right-sided paralysis and right-sided neglect.
So when you arrived on scene, a pre-hospital stroke assessment was done. This is the Cincinnati Pre-Hospital Stroke Scale, a very common scale used by most pre-hospital providers and also used in most emergency departments. It's very simple, abnormal or normal. Just one item positive can be significant. And it's valid because it catches about 80 to 85% of strokes, but it's not good for those posterior circulation strokes, and you'll hear more about that later in the talk. The stroke severity assessment, this is your LAMS score that you do, and this is, a validated 3-item motor deficit scale that identifies large vessel occlusions. It was developed for pre-hospital and emergency department use, and it takes about 20 to 30 seconds to do. There is good inter-rater reliability, and it correlates strongly with the NIH Stroke Scale, which again you'll hear a little bit more about, which is a much more detailed assessment. But a score of greater than or equal to 4 is indicative of a large vessel occlusion.
Okay, so back to our case study with this patient, E.T. They transported him priority 1 with the stroke symptoms that they found because they found a positive Cincinnati and he was a LAM score 4. His last known well time they determined was 15:40, so that was just 10 minutes before they called 911. EMS consulted Northwest Hospital. They were the closest hospital. They alerted Northwest en route, provided history and findings, and the patient's status was unchanged upon arrival.
One thing I do want to mention, there's probably somebody out there saying, why didn't we go to Sinai or a comprehensive stroke center? Sinai's a thrombectomy capable, and Hopkins, Maryland are comprehensive centers. This was September 15th. That pilot started on October 1st, okay? So again, we'll get into it, but this was not pilot time yet, all right? Mm-hmm. Sorry, go ahead. There you go.
Okay, so the patient got to Northwest at 16:18, which was just 28 minutes from the 911 call. The BAT was called, which is the brain attack or a stroke alert at our hospital. We call them BAT codes. So that alert was set off right away. The neuro PA arrived right away, and his NIH Stroke Scale score was a 20. Everybody's familiar with the NIH Stroke Scale score?
Okay. We are. There'll be a slide on that.
Okay,
so,
we'll show everybody a slide on that. It's
Yeah.
what we do at the hospital to do the full stroke scale assessment. These were his deficits that you can see up here. And on the head CT, we found out that he did not have a bleed. And that's what we're looking for on the head CT, if there's blood or not blood.
Okay, there's our question. What do you want to ask?
Oh, so with his symptoms right here, can anybody tell me what side of the brain you think his stroke is on?
Anybody who's not a doctor? Yeah. Okay, it's on the left side. Very good.
Yep.
Okay, go ahead.
And we know that from his left gaze preference and his right arm and leg drift.
So yeah, and being that he was mute also. Everybody knows that language is usually located on the left side of the brain. So that's another kind of a hint that it would be on that side. So we use at LifeBridgeHealth the BFAST scale, which is the FAST that you're used to, face, arm, speech, and then time, which we tell people to call 911, but it added balance and eyes. So we added this back in 2012. You guys added your cerebellar assessment just this year with the update, and I have that toward the end of our, the second half of our talk. But we added this early on because we were noticing in the ED, these were patients were the ones we were missing most often. And again, we'll get to a little bit of statistics on that later, but it was, it has been included now as of your July 2019 protocol. This is the NIH Stroke Scale we spoke about a minute ago. This is the scale, and this is the assessment that the providers, the neurology PAs, the neurologists, the nurses do when they're assessing the patient. It's an 11-item scale with a score for each item from 0 to 4. The max score is 42, although I've not seen a 42. But the higher the score, the more severe the symptoms. It is used as a predictor of outcome, and this was created actually as part of a research protocol for the original NINS trial, the trials that we were looking at the use of TPA in stroke. It is weighted heavier to the left hemisphere, and you will note that there are no points for those posterior kind of cerebellar items we were talking about, such as like dizziness or truncal ataxia. There is some limb ataxia in there, but it really is not weighted to capture all of those posterior circulations. So as good a scale as it is, it's not perfect.
Okay, so back to our patient ET. He did meet TPA criteria, alteplase, because he arrived to the hospital within the window of 4.5 hours. There were no contraindications. The risk benefits of TPA were reviewed with the family, and the bolus was administered from 63 minutes from the last known well time, and the door to needle time was 26 minutes, which is very good. And the reason why we can administer it so fast now is that we can administer TPA in CAT scan. So as soon as we have that CAT scan result and they're still in CAT scan, we bring the medicine right to them, and we can start the infusion, the bolus and the infusion there. We, since he was demonstrating signs of a large vessel occlusion, we performed the CTA-CTP at 1655, so that's right during the TPA infusion. And the CTA showed a left MCA and M1, M2 occlusion. So this is our rapid, which is the CTP here. You can see on the left side, which is the purple area, that's the area of brain already dead. On the right side in green, this is the salvageable brain tissue, which is the area of brain that's at risk for death. So this is what we use to determine if they are eligible to go for thrombectomy, which is the treatment where we pull the clot out of their brain, which we'll show you a video on later.
Okay.
So since there is a favorable mismatch, salvageable brain, he was eligible to go.
Right. So just a little bit about this rapid software. This is just a software used for the CT perfusion. And what it does is just gives you a really nice picture in real time about how much of the brain is already dead and how much of the brain is at risk. That's what we refer to as the penumbra, and I'm sure you've heard about that. So that green area is the area at risk that if we don't intervene is going to go on to continue to have a stroke and to die and turn purple over time. So we aren't able to do anything about the purple, and you're going to see a lot of these pictures as time goes on. You're going to see more purple, more green, less green, and you're going to see how we make a treatment decision based upon what this software is showing us. So it basically is just allowing us to have more information rather than using last known well, because we don't always see the person well. People wake up with strokes. I'm sure you're called often about that, and we don't have a time period, or it may be 20 hours. So this is allowing us to go in and look in real time, what does their brain look like? This technology has been installed on all LifeBridge hospitals, and we were the first in the state to have this system-wide. But I know now that other hospitals are getting this, so it's out there much more often.
Okay, so our patient was transferred to Sinai for a neurointervention. He got to Sinai at 1803. From EMS contact to Sinai arrival was 133 minutes, and he was an NIH Stroke Scale of 25 upon arrival. He arrived at 1812, and the reperfusion was at 1836. So the door from when he arrived at Sinai to full reperfusion was 33 minutes. He was a pre-treatment TICI score of 0 and post-treatment TICI score of 3. And we have a slide here to show you what a TICI score is. Is anybody familiar with the TICI score? So this is what the thrombolysis and cerebral infarction scale that we use to grade the perfusion. So 0, you can see here, is no perfusion, and grade 3 is complete perfusion. So we want everybody to get to a TICI 3 after thrombectomy, which is the best possible outcome. So this guy did have a good outcome. He ended with a TICI 3.
Right. And for those who are more familiar with cardiac, you may have heard of a TIMI score. So this is similar to it. The TIMI is just thrombolysis in myocardial infarction. So you may have heard of it with TIMI, so that's where then TICI came from.
So remember, he was an NIH 25 originally, so after thrombectomy, he got down to an NIH of 6, so that's good, and you can see his deficits here. And the next morning, he was an NIH of 4.
Okay, but he still has moderate aphasia and does still have some deficits, but definitely an improvement.
Right. So on the 17th, so 2 days later, he was discharged to Sinai Acute Rehab. On the 27th, he was discharged home with outpatient PT, OT, and speech therapy. And they determined that the etiology was most likely cardioembolic, but they could not detect AFib during his stay. So they decided that he would need outpatient cardiac monitoring to see if he actually did have AFib. So in the meantime, he was not put on an anticoagulant because they didn't detect AFib.
So a little bit about differentiating dysarthria from aphasia. This patient had both dysarthria and aphasia. So dysarthria is what we would call slurred speech. This is the patient that may sound drunk. Sound like they have marbles in their mouth. This is a motor speech disorder, and it results from paralysis or weakness of the facial muscles or the throat or the tongue. Common causes include, beyond stroke, it could be brain injury, brain tumors, Parkinson's, multiple sclerosis. On the other hand, aphasia is a language problem, all right? So the difference is depending on where it is in your brain. With a language disorder, what you're going to hear, it could be very clear words, but they're not going to make sense. Potentially, they're nonsensical. You might say to them, tell me your name, sir, and he'll say, Rapid Garage Hopper. And it'll be very clear, but it's not what you asked them, and it just makes no sense whatsoever. The person might be struggling to answer you. They might be looking like they're trying to get it out, but they really can't find the right word. They might also be mute, and you might have no response whatsoever verbally. This, as I said, results from damage to a particular area of the brain, and again, beyond stroke, this could be brain injury, tumors, migraines, even seizures that can cause this.
Okay, so now we'll go to case 2. On October 1st, Baltimore County was dispatched for a diabetic problem, and they arrived to find a 75-year-old male who just so happened to be the same patient from 3 days prior, who just had the thrombectomy. So he just had the left-sided stroke? Left-sided stroke. And now his wife called that he was not acting right, so EMS came to his home. He was nonverbal, and he did have a little bit of a slurred speech deficit from the previous stroke. His blood glucose was 131. He had unsteady gait and incomplete sentences, and he was incoherent. EMS determined that he was LAMS 3, so they took him priority 1 to Sinai, and they took him to Sinai since the wife told them he was just at Sinai. The previous time they had taken him to Northwest. So his last known well was at midnight the night prior, so it was almost 24 hours. The wife just hadn't seen him since the night prior, and she went to work. So they took him to Sinai. They alerted them for a stroke. An urgent stroke was called, so that we call within a 24-hour window. On the head CT, they got him urgently there. There was no bleed on the head CT. But this time they found an evolving right MCA. So he just had a left MCA 2 weeks prior, and now he has a right MCA infarct. So he is not an IR candidate because he's already infarcted. There's nothing we can do about it.
Okay. Now, does anybody kind of see the difference between one side and another? Okay? So it's right there, right? So that's a hypodensity that we're seeing, and that's why he was not a candidate, okay? And there you can see on the MRI in the same area, there's his stroke.
Okay, so
Yes? Sure, absolutely. Yes. So yes, when you're looking at it this way, this is the right side, and this is the left side. Sorry, yeah, they're flipped.
Yeah, when you're looking at the
when you're
scans.
looking at it, it's flipped. Good question. Thank you for asking that. And yeah, same thing here.
Okay, so he had an NIH scale of 14, and these were his deficits you can see right there. So they had determined previously that the etiology was likely AFib, but they didn't find it. So they said, again, it's probably paroxysmal AFib. So they did start him on Eliquis, the anticoagulant, right away, 5 milligrams. He was discharged to acute rehab, and then on the 18th, discharged to subacute rehab. He eventually was able to set up his tray, feed himself. He still had shuffling gait and needed supervision with his ADLs. He still had a little bit of expressive aphasia, and he was able to follow 3-step commands. So he still had some deficits.
Since it was so close to when he was discharged from the first occurrence, would it have made any difference if he'd been in the hospital? Could you have done anything faster for him?
Well, that's a really good question. The question was, since it was so close, it was 2 weeks from his previous admission, had he been in the hospital still, and had he developed these symptoms in the hospital, would we have been able to do anything for him? If faster, yes. If so, potentially. Of course, you never know, because we're going to actually talk about people who have strokes, and the strokes progress very quickly. But one would hope that if he had been in the hospital, it would have taken less than almost 24 hours for us to notice that he was having trouble. The reason in this specific scenario, the wife had left him with somebody while she went to work, and that person he was left with went out and left him alone. So that's why there was nobody saw him for till 9:30 that night. And again, if you had been in the hospital, you would have had somebody checking on you on a regular basis. So potentially, yes. But as you're going to see, we have people that come in very quickly after last known well, symptom onset right in front of someone, and we can't always do something for them. So excellent question, though.
Okay, so then the patient's wife did bring him home due to the bad experience that she had there, but then she ultimately did decide to send him to an assisted living since she couldn't manage him at home.
So a little bit about the background, and I'm going to go through this very quickly. The incidence of stroke in the United States, about 800,000 a year, and one occurs about every 40 seconds. And every 4 minutes, somebody dies from a stroke. It is the 5th leading cause of death and the 1st leading cause of disability. The different types of stroke: ischemic stroke caused by a blockage in an artery. About 87% of strokes are ischemic due to an embolism or thrombosis. You could also have the other 13% would be then hemorrhagic. And these can be, intracerebral hemorrhage as well as subarachnoid hemorrhages. And they each have kind of different symptoms to them. I'm sure you're all aware of the subarachnoid hemorrhage onset. You hear typically like a thunderclap headache or a very sudden onset. So these are just your different types of stroke. And then, of course, we have the transient ischemic attack. Some people call this a mini stroke. There's really nothing mini about it, so we really don't like that term. But it's very significant, a TIA, because it is actually a precursor or a warning for a stroke. A great percentage of people, 15%, when you think about it, go on after a TIA to have a stroke. So the way we find out about that is because they come in with their stroke and we say, hey, did anything like this happen to you before? And they go, oh, you know what? About a week ago, I had the same thing happen, but it got better. So I never thought anything of it, and I never told anyone. So that's how we kind of find out anecdotally that this is happening. So it really could be much more than that. Some common stroke symptoms, I've included this here, but as you're going to have a copy of this, I'm going to try kind of run through it quickly so we can get to more case studies, but just different signs and symptoms for the different strokes and in the different locations. And we'll talk more about brainstem stroke when we talk about posterior cerebellar assessment later in the talk.
The question
Absolutely.
So this issue of TIAs.
Yes.
How aggressively do you guys work on the TIA?
Yeah. Yes. Mm-hmm.
How much of a priority should we be giving them, right? We don't think TIA is priority one.
No, we're not, we are absolutely not asking you to do that. This is more of an education, don't ignore a TIA. We're not telling you to bring these people, rush them in priority one. They're not a large vessel occlusion. They can call you and say, I've had these symptoms. It may go away as you're transporting them. When they get to us, they may go away, but we don't ignore that. When they come in and say, according to our triage guidelines, if they have symptoms of a stroke current or resolved upon arrival, we assess them right there using the BFAST. If they are negative, so those symptoms have totally resolved, if they're negative for BFAST, we still work them up, but we don't work them up in like the urgent fashion, meaning get that CT in 45 minutes, get that blood work, because we're not giving them TPA if they have no symptoms. We're still working them up, but we just use a different pathway. But we definitely are keeping them, they're like on OBS, and we're working through based on their risk factors, because again, everybody's got different risk factors. We are working them up. So thank you for bringing that up. That was a great question. I have to talk about stroke mimics. I know that you're all seeing them, and I know this is where your struggle comes in, and believe me, we do appreciate it. You've got intoxicated people. We're seeing these people, and we're looking at them like, oh, these are all strokes. You're seeing everything, and you're the one who's having to weed through this and kind of go down your pathway and figure out what this person is. But hypoglycemia is a great mimic. Bell's palsy, seizures, people who are postictal, all these are really common stroke mimics. And we really, the goal for all of us is just to minimize brain injury and maximize the patient's recovery. And we do that by raising awareness, educating, and then partnering with you for the chain of survival, because really, believe me, we're telling everybody out there, don't drive yourself, don't get your family member to drive you, call 911, because we want you guys eyes on fast, because you're the one who's alerting us, and we can mobilize the team and be there waiting for you. And that's what we do. When we hear that you're calling in a stroke alert, that alert goes off to our team, and they know, BAT, 5 minutes out, 5-minute ETA, and we're getting ready to come down and see the patient. Just a quick nod to the assessment tools, why we have them, the Cincinnati, the LAM score. It has been demonstrated through rigorous research that without the use of these assessment tools, you're only got a sensitivity of about 61 to 66% for capturing stroke symptoms, whereas with the use of the tools, you're up to between 86 and 97% sensitivity. So these tools are working to help capture these patients. And just quickly, the pathophysiology behind large vessel occlusion, this is about 28 to 46% of the acute ischemic strokes that exist. And you are losing, or people are losing, about 2 million brain cells a minute while they're having a stroke. So again, that's what leads into that whole time is brain type thing. So the faster we can get them to definitive care, the better. This is what I wanted to talk to you about, the update with your EMS protocol update in July. This is where your posterior cerebellar assessment came in. I know you're all very familiar with this. But if your patient has a positive Cincinnati or a positive posterior cerebellar assessment, then you are, and they can get to the hospital within 20 hours, they are a priority 1 patient and should be coming to the closest stroke-ready primary or comprehensive center. I don't think we have too many acute stroke-readies in our little area, but they do exist now in Maryland, or they're really close to existing. I know we had to create the protocols and the policies or whatever for it. But you have a plethora of primary stroke centers and above in the area here. This is the launch of the LAM stroke research protocol, which, as we said, went live on October 1st. It is, this is where they documented, I don't know at this point, oh, what did I do? Sorry, okay. So no pointer, but you can see the jurisdictions that are participating, and obviously Baltimore County as well as City, Harford and Howard and Anne Arundel County are in there, and it's only a part of Harford County, it's not all of Harford County. But the participating comprehensive stroke centers as well as Sinai, which is the only thrombectomy-capable stroke center that is participating in this pilot. And within the pilot, we know if you have a suspected stroke, so Cincinnati and or posterior cerebellar scale positive, LAMs greater than or equal to 4, and symptom onset less than or equal to 20 hours, we're asking you to transport priority comprehensive or thrombectomy capable stroke center. That is within a 30-minute drive. All right, and then just a little plug for form completion. This is your, I guess you call them eMeds form. We used to call them run sheets in my day. But when you're filling out this form, as you're looking through it, you can see that the hospital capability, primary stroke center, oh great. The reason for choosing destination, pilot protocol, diverted from, it's entered. The GBMC is in there, over to the left. Here, okay. Might be able to do it here. Okay, so GBMC here, where it was diverted from. They've included that this was a stroke alert. Also, are you in a participating location, and did you divert? Oh, I'm sorry. Ooh. Oh, thank you so much. I didn't want to shut it off again. Thank you. Okay, so I would say that this is an A+++ completion of a form. This is fantastic. This gives us all the information we need because there are those of us who are collecting information for this pilot protocol. And once all of this information is gathered, collected, reported upon, you will hear about it, but right now we're just gathering data. So having a complete form is very helpful. Again, this is another good form, pilot protocol, diverted from Northwest. Yes, you bypassed a hospital. Fantastic. This one, not quite as fantastic. This is my head when I look at this because it says you chose the facility because it was closest, but you diverted from a primary stroke center. And when I say you, I don't mean you. I'm just saying somebody. So this is confusing for me. Is it confusing for everyone or is it just me? It is? Okay, good. No, I just had to make sure I wasn't misunderstanding something. So if we could get, and you know, these are rare, but if we could get them more like the other two, it would be fantastic. So that's just my plug for, please help us out by filling out the form, you know, noting that you did bypass a hospital, which hospital you bypassed, and include, like I said, the hospital that you diverted from. So on to some more case studies.
Okay, so this one is September 25th. At 9:06, a call came into 911 for a stroke. They arrived on scene to find a 71-year-old female, ANO ×4. She was walking around in her apartment, said she woke up at 6:45, felt some numbness in her arm. It never resolved, so she called 911 because she was worried she was having a stroke. They had a normal Cincinnati. LAMS was 0, so no symptoms. They transported her priority 3 since she had no symptoms, which was fine. She arrived at Northwest Hospital. She was alert and oriented, talking normally. She started getting registered at the hospital. Then all of a sudden, she became diaphoretic and unable to answer questions. She suddenly developed left-sided weakness, had a facial droop, and at that time, that's when a BAT code was called. The neuro PA arrived on site, and all of a sudden, she went to an NIH of 20. And you can see all of her deficits there. Right gaze, complete hemianopia, left-sided neglect.
Can you define hemianopia?
That's it's when you have like a field cut in your eyes, so you can't see. So in both eyes, you wouldn't be able to see one whole field. Like your peripheral vision is bad over here, so we'll test that by covering up one eye on the patient and saying, "Can you see our finger?" We'll test in both eyes.
And there's different quadrants, so you would be testing, you've got like upper quadrants on both sides, lower quadrants, in, out, so we're testing all of that, and that's part of what we test when we're doing like the NIH Stroke Scale and such. Great question, thank you.
So she had a field cut completely to the left, or one of her sides. She couldn't completely see.
Okay.
Was that the?
Is that what you want?
Oh, this, yeah,
Right?
this slide, yep.
Okay,
So
that's where you were.
the PA spoke with the neurologist, they ordered TPA, and in the meantime, they also got a CTA-CTP started to determine if she would be eligible for a thrombectomy. Door to needle time was 41 minutes, so that's great. And during TPA, her NIH went down from a 20 to an 11, which is some improvement, and these were her major improvements. She had complete paralysis to the one side. Now, all of a sudden, she only had a left arm drift. And then she had complete hemianopia, which is the whole field cut, just a partial, which means maybe just one quadrant she couldn't see. So this was her rapid results. You can see from the left side, no area.
No purple.
So you don't see any purple, which means no brain is dead yet. The green is the part of the brain that's at risk for death. So we want to save that brain. So she is eligible for thrombectomy. We took her. Her door in, door out time is 80 minutes. So that's good. Our goal time is 90 minutes. And it's very hard for us to meet.
Just to be sure. Oh, perfect. Excellent. This is just a little over 2 minutes. Oh, so I have to narrate because it's not working. Okay,
It's
so
supposed to have sound.
This is, yeah. So this is just showing you how we take a catheter and thread it up into the groin. They numb you first, you don't feel them. And some people are actually under anesthesia, so depending on if they're cooperative or not. But we thread it up into your groin and then up into your, it's going to go up into your like carotid and then internal carotid, then up into your, depending on where the vessel is, that is occluded. But this one is going up into the middle cerebral artery. Yeah, and you're not feeling any of this, so it's okay. And they thread the catheter itself all the way up till it reaches the clot. So it's really, when you think about it, it's got a long way to go. But as they thread the catheter up, there's also a sheath that goes over it. And you will see it's threading all the way up and then into and through the clot. And then there's a sheath that goes over it. So it's really that guide wire comes out. And then they exchange, because they have that sheath that's still there. They pull out the guide wire. Oh, and I guess this is the aspiration tube. So this is actually not the stent retriever. This is the aspiration tube. So this is a different kind of retriever. This is one which just does clot suction. So they pull this, they put this little suction, so it's kind of like a little vacuum, and they attach the suction, turn on the canister. This is one of the newer things that they're doing now. And then they have engaged the clot, and they turn the suction on, and they just, as the suction is working, you can see it's pulling blood and clot into the tube. And if you watch, you can see that the clot is ingested, and then you'll see you're going to have blood flow again through that vessel. Once that clot gets all the way out, you can see it maybe a little better, but there is blood flow. And then that's what they can use. Now, what the provider uses is based solely upon whether what they think is valuable, whether they want a stent retriever or if they want the clot suction itself. Yeah, we'll go back to the slideshow, and then what we'll do is if we have time at the end, I'll show the actual stent retriever one. You tell me when you think it's time for a break. Okay, wave to me or something. 15? Okay. Okay, so, all right. Okay. So the stent retriever would go up and then actually pull out a clot. It kind of turns into a basket. It engages the clot, and then it's kind of like it's like a net or a basket, and then they pull the entire stent out with the blood clot embedded in it, and then it would look like this. So there it is deployed, and that is what it looks like when it comes out with the clot embedded in it. And this is just an example of a before and after picture of somebody who has had, so this is the person who's got, you can see that there's a lot of vessels missing, not really good perfusion here. And once they pull that clot out, immediately you see all these vessels open up because now you've got blood flow. Okay.
Okay, we'll get back to our case studies. So this patient, MA, patient number 4, on July 31st of 2019, EMS was dispatched for chest pain to the YMCA. So 10:21, they arrived at the swimming pool to find a 64-year-old male, alert and oriented, lying down beside the pool. The bystander said he was acting weird and he was complaining of chest pain. The EMS providers actually noticed that he had a left facial droop, left arm drift, and slurred speech. So that got him thinking about stroke. He was positive for Cincinnati, but I did not see a LAMS documented, so I don't know if one was done or not. But they did transport him, priority 1, to Northwest Hospital. He then began to vomit en route to the hospital. So when he arrived at 10:38, he was drowsy. His last known well time was 9:50, so just right before they called 911, and then our BAT code was immediately called. His blood pressure was 202/113. And he had an NIH of 14 when he arrived. Right gaze, left-sided neglect. Okay, so this was his head CT. Can anybody tell me what you think this is on the CAT scan? That's not a doctor?
Yes, who yelled? That was
Yep.
right. Correct.
Yep.
Very
Right.
good.
Good, so they found hemorrhage, acute thalamic hemorrhage with mild ventricular dilatation. So in the ventricles, that's where the blood is going in.
You can see in the
Yep, that's
lateral
where the blood
ventricles,
is,
you've got blood
up
in
the
there too.
ventricles. Okay.
And the thalamus, yep.
So not a TPA candidate. So then he had to be intubated for airway protection, and his blood pressure was then 236/118. So they got a follow-up head CT to determine if this bleed was progressing or getting better, and they actually found out that it was a few millimeters larger, and the location of this bleed was typically of a hypertensive ICH, as you can see from his blood pressure. So they started him on a cardipine drip. His blood pressure came down to 178/103, and then they transported him to Sinai for further monitoring. During his hospital stay, he got an EVD, external ventricular drain. So I put a picture of it here in case anybody's wondering what it looks like. It treats hydrocephalus or swelling in the brain to help drain the CSF fluid. Okay. Then he started feeds the next day. He was extubated, and then he got a peg placement, the feeding tube from the stomach. On the 19th, he got a VP ventriculoperitoneal shunt placement. So this is kind of like the EVD, but this is a more permanent, so he can leave the hospital with it. It's not a drain coming out from your head. It's a drain that they put, and it goes down to your stomach to help relieve pressure from the brain, and that's where the fluid will drain. Then he was discharged to subacute rehab on the 23rd. During his follow-up visit, a couple weeks later, he was still in rehab, but he came to the neurology clinic for a visit. He was alert and oriented to himself. Speech was minimal but clear. He was able to follow simple commands. He still had a left facial droop and left hemiparesis, and then he also got his staples removed. And we hadn't had any follow-up since then. Okay, any questions? Okay, so FP is patient number 5, so this is from January 24th, more recently. 1951, Baltimore County EMS was dispatched for a seizure. And they arrived and found an 81-year-old male lying on his back in bed with vomit around him. So they suctioned his airway. These were his vital signs here. Blood pressure 218/103. And his roommate stated that she saw him eat dinner, but then she walked into his room to find him gurgling. He was responsive to only to painful stimuli. So they were dispatched for a seizure. This is how they found him. No Cincinnati or Lambs was documented, so I'm not sure if they were thinking stroke. Would you guys be thinking stroke if you came upon this case?
Right.
Some say yes, some say no. So I didn't see a Cincinnati or Lambs documented, but the only indication maybe they were thinking of stroke is in the narrative I saw the rule out hemorrhagic stroke. But they did transport him priority 1, which is good, medical notification to Northwest. So he arrived at Northwest Hospital, and the nurse documented that his complaint was seizure, but at triage in the hospital, the nurse noticed that he did have a left facial droop and his left side was flaccid. BFAST positive on all elements, and that's when they called the BAT code. So this is, you can see, might be not typical of a stroke presentation. This is what the provider documented. Right arm and leg moved to noxious stimuli, poor corneal reflex on the right, good on the left. NIH Stroke Scale was a 29, and we determined his last known well time was 1900.
So you can see the difference here. I mean, he's unresponsive. He's not protecting his airway. So, not your clear cut. This could be, kind of anything. It's not a clear cut right up front that this is a stroke, but it's upon further assessment that is done. We certainly don't expect you to do corneal reflexes when you're out in the field. Please don't. Yeah.
Okay, his history is that he had hypertension and previous MI. He was just on blood pressure meds. Other than that, he ambulates independently. He was healthy, cares for himself, shops and drives himself, so he was an otherwise pretty healthy guy. So after arrival, he had to be intubated, and they got him in the CAT scan. And on the CAT scan, they found a dense right MCA, and they did not see any blood on the CAT scan. Can anybody see where the dense right MCA is?
Can you tell me which? I see you pointing. Go ahead. Right. Left side of the screen.
Yeah, so it's a right, so it'll be on the left side of the screen.
Right here. Very good.
Yep.
And there it is.
Right there. Okay, and they got a CTP on him.
So what do you
So this is his rapid result. We were trying to decide if he would be eligible for thrombectomy. What do you guys think for this patient? Would we send him for thrombectomy or would we not?
No. I see head shaking no. I see head shaking yes. Okay, you're saying no. Why are you saying no? I'm not saying you're wrong. I just want to know why.
That wouldn't have any effect.
Okay. And you said yes? Okay. So valid. Everything's valid. So the correct answer is no. And for the reason you just said, it doesn't look like it would be of any use. And the reason that is if you look at the purple and the green, they're pretty much equal, right? So the purple's the dead part, the green's the at-risk part. If you've already got most of the green dead, there's nothing for us to save. But that's, this is what we're looking at. And we never know, because if you notice, this, Eve just said, they ate dinner, and the girlfriend walked into the room a few minutes later and found him gurgling. Last known well was, she witnessed it almost, within a few minutes, right? So this man had, go ahead, you can fill it in.
Okay, so we just described matched perfusion. So we want a mismatch, but this is matched. So he's not eligible for thrombectomy. And he had poor collaterals, which we'll get into later. Sometimes the other vessels in your brain help perfuse the brain, but unfortunately this guy had poor collaterals, which was a rapid stroke progression. I mean, his last known well was just shortly prior. So unfortunately, his stroke had already completed.
So this is what we're going to talk about a little later in the discussion is I know for those of us who've been doing this for a little while, it was time is brain, time is brain, time is brain. You want to get people in very quickly. But this is just an example of reality. Brain is brain too. Everybody's brain is different. Everybody has, different vessels that are working, atherosclerosis, other comorbidities, other risk factors. And if you have poor collaterals, even if we catch you at moments after you have a change in condition, this is what might happen. So no matter how fast someone gets to this person, we weren't able to do anything further for him as far as intervention. But we don't know that. Nobody can look at someone and say, oh, your collaterals are lousy. So we never know that. We just have to act on everybody and act as if we possibly can help them until we know otherwise. But that is why the choice was made as it was in this scenario.
So knowing all that, he was within the TPA window, so 4.5 hours or less from last known well. So the neurologist discussed the risks and benefits with the family, and the neurologist told the family it's unlikely that TPA would provide any benefit. There's a high risk for bleeding. He has a grave prognosis. The family decided they still wanted it since this was really their only chance to help the patient. Door to needle time was 72 minutes, but that was because the family was deciding, and we had to intubate him. And then we sent him to Sinai ICU for closer monitoring. Door in, door out was 2:37 minutes. Follow-up PET CT showed an evolving large right hemispheric infarct with hemorrhagic transformation. Can anybody see the blood in here? So this is what TPA can sometimes do. That's why we tell everybody there is a slight chance of bleeding with this TPA. Okay, and you can see a little bit of blood right there on the CAT scan.
And now the risk, yes?
Does this particular presentation have a higher risk of bleeding?
You're excellent. That was going to be my next. Perfect. No, thank you. I'm glad you brought it up. So what I was going to say was, in this particular scenario, because you have someone who already had a large part of their brain that was showing, an infarct, no perfusion, they were at higher risk. Anytime you have like a large stroke, there's other risk factors to a higher potential for bleeding. It can be age, it can be other comorbidities, but certainly when you've already got brain tissue that's damaged, now he didn't have any bleeding, and there was nothing to say, no, you can't do it, but we were very clear with the family because he was within the window, and remember, we saw him go, pretty much, it was minutes from last known well, and there was no IR that was going to help him. We did say, this is the only thing there is. We are letting you know there's a very high risk of bleeding here. But the family absolutely, said they understood that. They still wanted to go forward, and they were aware that this would be a risk. Now, I can tell you additionally that had we not given him TPA at all, he still could have bled. All right, so that people who have large strokes are just at higher risk for bleeding. So it's not all about TPA or no TPA. It's just another, something else that adds a risk to it. But we have people that bleed that don't even have, that haven't received TPA. Anybody else? Yes.
If the patient gone to Sinai and they had IR there,
Mm-hmm.
with the same perfusion scan, would they have done like a thrombectomy, or would there be no benefit?
No. So So Sinai is the only place that does IR. I mean, it's the thrombectomy capable center. So when we have the rapid scan that was done at Northwest, the neurologists from Sinai are the ones looking at it. And we determined that IR would not benefit this person. No matter where he went, IR wouldn't benefit him. So that's why it was determined that he could not have IR. Yes?
Can you just repeat his question?
Oh, I'm sorry. Yeah, so the question was, if he had gone to Sinai, would he then have received IR had he gone there? But it doesn't matter where he showed up. If he had gone to University of Maryland, he wouldn't have gotten IR. Nobody would. I can't imagine anyone. I guess I can't say nobody would do this. But looking at that rapid profile where you're matching the dead tissue with the tissue at risk, you have nothing to save is what it comes down to. So people aren't going to go in there because it's going to be futile. Okay, anybody else? Okay, so would now be a good time? Okay, so I think is there one more slide? I'm sorry.
His very
okay.
poor outcome. He went to
Yeah.
hospice and he ended up being deceased 2 days later. So this is one of the poor outcomes. We do have a lot of great outcomes, but this is a patient that we worked up quickly. We got everything going, but unfortunately he did pass away
So, yeah.
due to the large stroke. We did everything we could. Okay.
So as promised, I know there was a lot of concern when the protocols changed and you added the posterior cerebellar assessment. And I heard it from everybody last year when I did this presentation. Oh my gosh, dizzy? You're going to get every dizzy person in the state of Maryland. And I know there was a concern on your end and, probably some concern on the ED's end too. But I'm here to tell you that we, in fact, did not get every dizzy person in the state of Maryland. But I'm going to help you, hopefully, understand a little bit about the posterior circulation and, dizzy by describing for you what we call dizzy plus. So posterior circulation, certainly people can be dizzy, but generally it's not just dizzy. So dizzy plus, and we'll go through, I know this is very busy, but you're all going to have a copy of this. This was just a little bit of information about the areas of the brain that is, fed by posterior circulation, by the blood vessels in the posterior circulation. And we're going to really focus more so on the brainstem and the cerebellum. So for people that remember, brainstem is made up of the midbrain, pons, and medulla. And you could see symptoms from this area of limb weakness, sensory loss. They can have cranial nerve palsies, some crossed signs, as well as something called locked-in syndrome, which we're going to talk about. And then for the cerebellum, which is right here, this is also fed by your posterior circulation vessels back here. I'm not going to say what they are, but the symptoms you might from this area would be vertigo, ataxia, nystagmus. Everybody's familiar with nystagmus, right? Okay, so nystagmus would be if your eyes are kind of like jerking. Has anybody tried to have somebody follow their finger when you're doing an exam and people's eyes kind of bounce or jerk? So that would be nystagmus. I know sometimes we do see it on the eMed sheet, so I know it is documented at times. But that is something that you might see. So just to get into a little bit more detail, we said the brainstem right here is made up of the midbrain here, pons right here, and the medulla. If you remember, you have 12 cranial nerves. 10 of those arise from the brainstem. The major functions that occur or that come out of the brainstem are your eye movement, your swallowing, breathing, blood pressure, heartbeat, basically consciousness, level of consciousness. So this is kind of your regulatory area. So this is why you might see somebody who has a brainstem stroke who has a decreased level of consciousness, sometimes even comatose. Okay? And remember, when you have your arteries going up into your, you have like you have two vertebral arteries at the back here that come up to join and form one basilar artery. So if you only have one artery and you clog off that one artery, you've got a problem, right? So as far as your cerebellum that we talked about, and that's this big thing right back here, this area is responsible for movement, specifically balance and coordination, and I'm going to get into that a little bit when I talk about ataxia. But just a tiny bit about background. Your posterior circulation strokes really only make up about 20% of your ischemic strokes. And we already said that ischemic strokes are about 80% of strokes. So 20% of that are posterior circulation. But it can be as many as about 165,000 strokes per year that are misdiagnosed that are posterior circulation strokes. So that's why, as I told you earlier, we added BE, balance and eyes, to our BFAST, because we noticed that we were having patients coming in with dizziness, balance problems, nausea, and they were negative for facial droop, arm drift, or speech problems. So we would think that was a negative Cincinnati, but yet they ended up having a stroke. So we noticed that we were missing them, and we knew we had to do something about it, and that's when we added the BE to our FAST. Again, these people are 3 times more likely to be misdiagnosed, because imagine, take all the people that you see. If you looked at your dizzy, people who say, I'm really dizzy, or I'm really lightheaded, or giddy, or I've been really nauseous, I'm sure that the very first thing in your head is not, oh my gosh, you're having a stroke, right? Right? So it could be you're dehydrated depending on the time of the year. You were mowing the lawn. It could be you have the flu. Maybe you've got a virus. But you're not going to jump to stroke. That's why we had to add in that ability to screen for this. So I said dizzy plus. So for posterior circulation stroke, we have the 5 Ds and the 3 Ns. And this is, I'm hoping to help you a bit with your dizzy patients. All right, so your 5 Ds are dizziness, which can be vertigo, lightheadedness, giddiness, however the people describe it to you. Diplopia, which, you know, double vision, and it doesn't have to be double, it can be visual changes. Remember, these are acute onset of things, all right? Dysarthria or slurred speech, dysphagia, not aphasia, but dysphagia, which is trouble swallowing. This can be drooling, this can be coughing, choking. And did everybody in here know that if people, sometimes when somebody eats and they start tearing, that could be aspiration, that could be trouble swallowing? That was something I learned early on, and that was like news to me. Just tearing. They're not choking, they're not coughing, just tearing. So that could be trouble with swallowing. And then dysmetria or ataxia. So dysmetria would be like when you ask someone to touch their nose to your finger, you hold the finger out here, and if they, instead of going from here, they do like one of these and they miss, and that's called past pointing. Or ataxia, and I'm going to really get into a little more detail on that. That would be somebody who's got like uncoordinated movements. We talked about it was affecting their arms. You would have like finger to nose, past pointing, but it could also affect their walking. So this would be somebody who's kind of going to try to compensate for it, so they're going to have like a broad-based or wide-based gait. But they're going to have some kind of like staggering ambulation when they're walking. It kind of resembles like an intoxicated person who is off balance when they're walking. And the reason that is because the same area of the cerebellum is affected by alcohol as it is if you're having a stroke in that area. Okay, so these are what I went back to here are your 5 Ds. Okay, so it's not just dizzy, it would be dizzy plus. So dizzy plus something else which could be one of the other Ds. It could also be one of the Ns. And the 3 Ns are nausea, numbness, and nystagmus. And we already talked about nystagmus, so abnormal eye movements. Remember also when we were talking about the cranial nerves coming out of the brainstem, you can also have, beyond nystagmus, you just could have like an eye movement problem. You can have eye deviation, skewed eyes. So one eye's looking one way, one's looking another way. So it could be, that's part of your cranial nerves that your eyes aren't able to, you can have a gaze preference. We talked about that earlier too, where, people could, it may not be together that the eyes are looking to the right or left. It could be one's going one way and one's going straight. Okay, so just some eye movement abnormalities. Yes, I'm sorry.
What's the incidence where somebody has isolated numbness in their arm, no other symptoms, they can still move their arm, and they still are having a stroke?
Yeah, absolutely can happen.
And what's the, is that?
I don't have numbers, I'm sorry. I can't, but I can tell you we've had somebody come in like that who actually came in initially with just arm numbness, and then eventually progressed to actually weakness and did have a drift. But they didn't initially have that. But their first complaint was just the numbness and tingling. So, because you have a sensory strip, you have a motor strip, so you definitely can have isolated sensory symptoms. And it really, it's kind of a little more than I can get into in here, but it really plays into where in your brain you're having that stroke. And if you hit just the right spot, you can have isolated sensory symptoms. Okay, anybody else? All right, so we have our next patient.
Okay, we have a case from August of 2019. At 1850, this is Carroll County EMS, was dispatched for a stroke. They arrived on scene to find an 83-year-old female in a chair, alert and oriented to her name, but she was unable to speak. No function of her left side and left facial droop. These were her vital signs right here. Her last known well was 1810, so just 5 minutes before the 911 call. She had a positive Cincinnati and a LAMS of 3, so she was transported priority 1 to Northwest Hospital. A back code was called right away, and her NIH Stroke Scale score was a 10. She had aphasia, left side was flaccid, and facial droop. Her head CT showed that she did not have a bleed, and her door to needle time was 32 minutes, which is great. So during TPA, she came down to an NIH Stroke Scale of 4, where she had mild aphasia, but still severe dysarthria. We got her CTA, CTP. So as you can see here, there's no purple, so that means none of her brain is dead. And the green is at risk for death, and this shows a basilar occlusion. So you can see it in the center of the brain there.
Okay, so not on one side like we've been seeing previously, but right in the back in the center kind of.
So we transferred her Sinai for thrombectomy. Her door and drop time is 100 minutes. Not too bad. She arrived to Sinai. Her door to reperfusion time was 49 minutes. And from the time she called 911 to full reperfusion, 222 minutes. This was before our protocol pilot.
And she came from Carroll anyway.
Oh,
so she's
yeah,
not
she
part
came
of the,
from
she
Carroll.
wouldn't have been part of the pilot anyway.
She had a Tiki score of 3, which is good, full reperfusion. And her MRI did show an acute cerebellar infarct. So she was discharged home with home PT and follow-up with cardiology. And she had pretty good outcome. She was neurologically all back to normal, everything except driving. She was cleared to drive after she self-reported her stroke to the MVA. And her cause of stroke was the atherosclerotic plaque in her aorta. So she was put on Lipitor. She wasn't taking that before. And she was supposed to cut back or stop smoking, but she just cut back on smoking.
Some people just don't want to give them up.
So in our 90-day follow-up phone call, she was a modified Rankin scale score of 0. So what that is, this determines their disability after the stroke. So 0 means they have no symptoms after the stroke. And we score them from a 0 to a 6. 6 is dead, 0 is no symptoms. So she had no symptoms, was back to baseline, And in her follow-up in December, she still cut back smoking but was not able to quit. Still is taking her Lipitor, and she's chose herself not to drive anymore.
Okay. So our next,
Can I ask you a question?
yes.
So if I'm correct, if I'm wrong, but this could be really off. So even if that was participating in the pilot,
Yep.
her lambs was less than 4.
Right, so she wouldn't have, right, correct, correct. Closest, right. And it just so happened, even though it says Carroll County EMS brought her, it just so happened that where this person was in Carroll County, it was closer to Northwest than it was to Carroll Hospital. But you're correct. With the lambs of 3, she should not have come she should have not have been a bypass. It's 4, that's correct,
Lambs
4
of
greater.
4.
So thank you for, for
Online.
the part about the lambs of 4. Oh, so the question was, just to clarify, even though this was, we said prior to the pilot,
Yep.
this patient had a LAMS score of 3. So with a LAMS of 3, you do not bypass the closest primary stroke center. You go to the nearest primary stroke center. And even though it was Carroll County EMS, it just so happened that wherever they were located in Carroll County, Northwest Hospital was closer than Carroll Hospital was. But the patient went to the closest primary stroke center, which was correct for a LAMS of 3, and that's where they were treated there and then transported from there to Sinai Hospital. Okay, is that
Yep.
good? Okay, great, thank you. Thanks for that question.
I think this was your
Oh,
case.
yes. So our next patient was from August. There was a 911 call for stroke. There was a 55-year-old female who had told her family and friends that she didn't feel well, and minutes later developed slurred speech and what they called incomprehensible words. She did have a history of mitral valve replacement 20 years prior, and then had a stroke as a child from rheumatic fever, but with no current deficits. Her last known well was 6 minutes prior to the 911 call. She was Cincinnati positive, but a LAMS of 0. She was transported priority to stroke to an outside hospital, and there was a mention in the narrative that every CVA indicator is negative except the patient's inability to form words and speak, which is positive on a Cincinnati. So she arrived at this outside hospital. They confirmed the last known well of 9/25. EMS did report 2 episodes of vomiting en route, for which this patient was given Zofran. The patient could nod yes and no to communicate, but other than that, she had severe dysarthria and aphasia. She did get, her blood glucose was 139 and her NIH Stroke Scale was 6. She had 1 wrong during that NIH Stroke Scale for the month and age, and had a facial droop, and as we said, severe dysarthria and aphasia. She was eligible for TPA because it was called in very quickly, and TPA was recommended by the neurologist. So the risk and benefit was discussed with the patient and family, and they agreed to proceed. As they were getting ready to mix the TPA, the patient became bradycardic to the 30s and had an episode of nausea and vomiting. All right? We then still were going to move forward with the TPA, but she had another episode of bradycardia, and this time vomiting black emesis, all right, which was gastrocult positive, so there was blood in her vomit. So now she's no longer getting TPA, so she didn't get TPA.
Bleeding.
She's already bleeding. We don't want to make that worse. So we did recommend a CTA and a CTP on this person. So we've got someone who's becoming bradycardic and someone who's vomiting, along with their dysarthria and facial droop, I think they had. So anybody have a guess where this stroke might be? I don't need you to get real particular. Right, left, front, back? Posterior or anterior? Posterior, okay, good guess. Especially since we just talked about Dizzy Plus, right? Mm-hmm. So here's our rapid, and here's our patient with another basilar occlusion. Again, nothing showing up here, so nothing No core yet, but we are seeing decreased perfusion. So this patient was transferred to Sinai. By that time, her NIH Stroke Scale was 3, so it did improve, even without TPA. She was noted to be an AFib, which was new. That was not part of her history. So when in the outside hospital, they did have runs of AFib. Again, as we talked about it with her previous history of mitral valve disease, she did have a valve replacement with that. So she went to IR. She had a door to puncture of time of 23 minutes, door to revascularization of 45 minutes. Her last known well to arrival at Sinai was 185 minutes, which really isn't bad when you consider that she had to stop at another hospital and then get to us. And she did have TICI-3 revascularization. And here are some pre and post angiogram. Again, you can see how this is the vessel where you're not seeing any blood vessels, and then after you are. So you're seeing blood flow here. And then same thing here. All right, not so much with the, that you can see the blood vessels, and here you are. Here's her MRI, which shows scattered cerebellar infarcts, and there, as you can see, the kind of the white areas all over here. So she definitely did have a stroke, but yet her NIH Stroke Scale ended up as 0, and she was not exhibiting any deficits. She did go to outpatient OT and speech, so she might have had a little bit of, cognitive issues, or, something that was so minor it really wasn't picked up on the NIH Stroke Scale. But she did end up on Coumadin or warfarin for her mitral valve, and because they saw the, they saw the AFib. In her 90-day follow-up, her modified Rankin scale was 0, so she was back to her baseline, able to do everything she did prior to her stroke, and work. So considering how poorly people can do after a basilar stroke, this lady was incredibly lucky and did very well, and everything worked out very well for her. Not everybody works out quite so well. Just like the bleed we saw earlier, some people don't have a good outcome. This patient was a 69-year-old female from December who arrived to an outside hospital, came in complaining of 2 days of vomiting, double vision, dizziness, shortness of breath, weakness, ringing in her ears. She kind of had a constellation of symptoms, so it wasn't just, coming in with right-sided weakness. This was just really feeling lousy and having this kind of, multitude of symptoms for 2 days. When she arrived at the outside hospital, she was awake, alert, oriented ×3. She was weak globally, like a 4 out of 5, so not dramatically weak, but there really was no focal neurologic deficit. Everybody knows focal is like attributable to one area. So it was more global for her. She did get an NIH Stroke Scale score of 1 because she had a partial gaze palsy. So something that wasn't right with her gaze. But that is the only thing that was wrong. She had no abdominal pain, diarrhea, and again, no focal weakness. While in the ED, she deteriorated significantly. She had an NIH Stroke Scale of 11 plus, and I say that because she had at least an 11, and there were many items on the scale where the person doing the assessment just said untestable, untestable, untestable. So I'm quite sure, based on how she arrived to our facility, that it was more than an 11. She was obtunded and ended up being intubated for airway protection. We recommended a CTA and a CTP and found that she had an occlusion of her right vertebral and basilar artery. She was clearly with 2 days of symptoms outside of the window. Even though she deteriorated rapidly in the emergency room, remember we said she had a gaze preference, or gaze palsy, right? And that's how she came in. So we're not sure exactly when everything started. We do know that she deteriorated in the emergency room, though. She was transferred to us initially because she potentially may have needed surgery. Once we were able to view her CTA and CTP, we planned for neurointervention. When she arrived at Sinai, her NIH Stroke Scale was 29. You can see all of the deficits that she had. Our team was able to do a complete NIH Stroke Scale, so we didn't have any of this like unable to determine or untestable. But they listed everything. Certainly she was intubated, but she had no effort against gravity at all in all 4 limbs. So this is what we had when she arrived. She was taken to IR. Her door to IR time was 6 minutes, door to groin 25 minutes, door to revascularization 142 minutes. It took a long time to get up into the basilar artery and vertebral artery. It's harder to go there than just to go into your straight up into your MCA when we were talking about the anterior circulation. She did have radiographically TICI-3, so full revascularization. How people do radiographically and how they do clinically is not always the same. So even though we opened up the vessels, you will see, and here's our example of how her vessels opened up. And here's her MRI. The following day, her NIH Stroke Scale was still relatively high at 27. On day 5, she could open her eyes to voice, nod appropriately, but had no spontaneous limb movement. On day 8, she was trached and got a peg. During her stay, her course was complicated by some GI bleeding and some pneumonia. She was still an inpatient at day 34. And based on this, her prognosis was not good. So this is where we get into locked-in syndrome. Has anybody heard of locked-in syndrome that is not a doctor or a provider, like a PA? Okay, so locked-in syndrome is, I don't know, it's like, it's best described, I don't know, death while awake. There are a lot of people who can communicate. A lot of people say, given the choice, they'd rather be dead, because when you're locked in, first of all, it has to do with it's damage to the pons, which we went over earlier was part of the brainstem. And in that area of the brainstem, there are pathways between your cerebrum and your cerebellum. And when these motor fibers are interrupted, this is where, like we said, you're controlling speaking, facial movement, all those kind of movement at all. It's all kind of controlled in that area. So this is damage to this area results in this syndrome, this locked-in syndrome. And I don't know if people have heard about this book, The Diving Bell and the Butterfly. It's about somebody who is locked in. So that's just a book. They were able to communicate, and I'll show you how that can happen. So when you are locked in, you're awake and you're fully conscious. Your cognition is intact, so you know everything that's going on. And you're able to feel pain, but you can't communicate. So, except by eye blinking. So imagine you're laying there, you can't move, you can't, fight back, you can't, let people know what you're feeling. Basically, all you can do is you're moving your eyes. And now, what degree of this you have, we'll get into a little bit more. But if you fully are locked in, there's usually no other voluntary movements. And you have to hope, and people are trained in the hospital, in the ICU, neurology, critical care specialists, and nurses are trained to look to see when you're thinking the patient isn't able to communicate, to look that they can, to see if they have eye movement, look to see if they're tracking you in the room. Just because they can't speak, just because they can't move or follow commands, you want to make sure, especially when you're looking at this kind of injury, if they're, want to make sure that they're not locked in. And if they are, you want to make sure that you're communicating with them because they can hear you, okay? And they know what's going on, they just can't let you know that. So like I said, there are varying degrees of this. So People may retain some movements. They may have horizontal gaze, some facial expression. Sometimes they may have tongue movements, or be able to move their head a little bit. At one point, they thought that this, once you had this and whatever you were like right after this happened was it forever. That's what they used to think. But there are some people that do regain function over time, whether it be just a little bit of an arm movement or a finger. But the majority of people are severely impaired. It's just a very small amount of people that have a good recovery, and I don't even know if you could call it good. But there are people who are able to, I would say these people are dependent, but they are able to have some quality of life. There are computer systems now that if you can either blow or bite on a straw or have some kind of movement, even with your eyes, you're able to communicate through this computerized system. So again, it's not available everywhere, but there are some ways that these people can communicate and have, like I said, some quality of life. Hospital day 37, this patient was discharged to subacute rehab. She was able to communicate via nodding, able to wiggle her toes on her left lower extremity consistently. So when they would ask her to move her toes, she could move them. And then, tell her to stop, then have her move it again. So she definitely was following commands and moving her toes, so she could just move her toes. And then she could minimally assist with elbow flexion if they kind of like tapped on her muscle. And she was able to communicate. She can feel pain. So how much this will change for her, I don't know. But this is how she left, even though we acted, and did everything as soon as we could. So when we've talked about all of these scenarios, we've given you, you've seen people who have come in immediately. You've seen people who've come in almost 24 hours later. And you've seen that when we're talking about time is brain, we always want to get people to the best care possible, to the most appropriate care. Speaking to now with the pilot trying to speak directly to an interventional center when you know that you have a potential for a large vessel occlusion. It's about time, but as you can see, it's not all about time. It's also about collateral circulation, as we talked about with the gentleman who was seen to drop or was seen to decompensate, and then immediately he got this huge stroke that we can't do anything for. Really, what predicts a good outcome is the infarct, the volume of the core, the area that it is in, that's the eloquence of the tissue. And we talked about people who have poor collaterals are the people who are going to have what we call a malignant profile. This is somebody who goes on to have a stroke and goes on to progress very quickly because there is no other way for the blood to get around. Patients who have good collateral, it's kind of being on the beltway. So if you're on the beltway and there's an accident, you're going to try to get off on an exit if you know the accident's coming up. But if there's no exit to get off of, you're stuck. So kind of think about that's how circulation, the circulation in your brain is. If you have collateral and have these go around so that you can perfuse your brain, you're going to be in better shape than somebody who's got nowhere to go. So I'm going to leave you with this patient who came in yesterday. Hot off the presses, right? He's so hot off the presses, I don't even have the EMET sheet for him, so I can't give you all the details. All I know is he came in with Baltimore County EMS, and I don't know what you were dispatched for, but it was a 57-year-old male, so a baby, 57. History of hypertension, last known well at 6:50 in the morning. His only history is hypertension. The only medication he took is hydrochlorothiazide. He had left-sided weakness, facial droop, speech problems, and an inability to stand. His Cincinnati was positive, but again, and I got that off of the report coming in, but I don't have anything else. He was transported directly to Sinai, where we found an NIH Stroke Scale of 11. So you can see he had a gaze palsy, a complete hemianopia, partial or complete paralysis of one side of his face, no movement against gravity in his left arm, and he did have neglect. His IV-TPA door to needle time was 25 minutes given in the CAT scan, and we did do a CT perfusion, and you can see here where a little bit of purple, so a little bit of core, and a large amount of penumbra, so a large area at risk here. He does have a right M1 occlusion. So we took him in, and here's his initial angio, and look at this reperfusion. All right, same thing here, just a different view. Huge amount of difference there. And his MRI does show a small stroke, or well, not a small stroke, but a stroke there, you can see that. However, his door to IR time was 35 minutes and door to reperfusion was 81 minutes. Immediately post-procedure, his NIH Stroke Scale was 0. He was moving as he was coming off the table. At 24 hours, it remained 0, and in fact, he was discharged home today. Home. This is 24 hours later, all right? And he's going to be following up with neurology and cardiology. Yes?
Do you think that given the advances in neuro-IR, the vast majority of these cases had some neuro intervention? Do you think that there will come a time when we're going to start moving not just between 4 and 22 hours, but for the majority of stroke patients, right to a thrombectomy center?
So you're saying bypass all primary stroke centers, or what?
So I'm saying that
Yeah.
the difference between primary stroke and comprehensive is the ability for neuro-IR and large vessel.
Right,
epilepsy.
right.
All of these cases you shared, whether
Right.
they got TPA or not, the vast majority has CTA, CTP,
Oh, correct.
right?
Yes.
Mismatch.
Yeah.
And then went on for a neurointervention.
Okay.
These cases required transport from a primary care stroke to a comprehensive. Do you think there's going to come a time where we in EMS more frequently are just going to be going to neuro-IR capable centers?
Okay, that's a great question, except what I'm going to tell you is, first of all, your presentation is biased.
Yeah.
If I just tell you, I threw these, we cherry pick these because they're interesting. A bleed, the bleed was interesting. If I just loaded you with door to needle, door to needle, door to needle, I mean, it would have been like, yay, okay, got it, door to needle. I did this to show you the advances and the things that we're doing and to tie it in with what we're asking you to do by bypassing. We are definitely, remember what I said earlier, that only 26 to 48% of the patients are a large vessel occlusion. The rest of those patients are not eligible for intervention. So those are the patients that are getting IV-TPA only. And we are giving them IV-TPA and not taking them to IR. Because we're doing these, if we do these CT perfusions or CTAs, there's no clot. And then we have nothing to go after. Therefore, we just give them TPA, and they can do well too. But if there's no clot, we have nothing to go after, and they just get TPA. And those patients are perfectly fine to stay at a primary stroke center. In fact, we do have primary stroke centers that do treat a patient, and then they do a rapid, or they'll do a scan, and we pull it up, and we say there's no clot anywhere. So there's nothing for us to go get. Or their clot is so distal, far away, far out in the vessels, like to the tiny ones at the very end, we can't take any catheter out that far. So there's definitely still the need for a primary stroke center and what a primary stroke center can do. Additionally, if you start flooding, and I don't mean flooding, but bringing all of the patients directly to a comprehensive center or a thrombectomy center, then we're not going to have beds for the people who absolutely need our intervention, a neurointervention. So there is absolutely a need for a primary stroke center. And additionally, I would add, it's very expensive to have a team in place, multiple teams in place that can do neurointervention. Not every hospital can afford that. Not every community can support that. We are incredibly fortunate in this Baltimore, Maryland area that we have so many great, we've got Hopkins, we've got Maryland, Sinai can do thrombectomy. There are I can even tell you, hospitals and rural areas throughout the country where they're not even able to give TPA. Because they have these tiny little, 4-bedroom or 4 kind of room emergency rooms that people are going to, and it's hours to get to any kind of hospital that can admit anybody. So we're incredibly lucky here, really fortunate to have what we have. Okay. I know it's really close to the end, guys. And I really appreciate your patience, since I know this is brutal, 2 hours. Yes?
Would there be a possibility of eventually having the NIH scale available to field EMS?
Can you repeat the question?
Do you want to repeat it?
Would it be possible to have the NIH?
Do you want me to do it? Oh, I'm sorry. I have to do it because of the microphone. Sorry. So the question was, would it be possible to have the NIH Stroke Scale available to field EMS? This is not a scale that is only allowed to be used in the hospital, but I can tell you it is something that takes longer to do. And I know everybody out here it's about quickly getting people to definitive care. You're supposed to be like, kind of treating them, assessing them, deciding where they need to go, and, figuring out what this is and following your protocols and getting them to where they need to go. I will tell you, we like to use the term doesn't change management. Will what you're doing change management? What you're currently doing is appropriate for managing the patient and for deciding what's the best place for them to go. A quick scale, Cincinnati and Lambs. We've moved now to Lambs, where we're identifying a large vessel occlusion. You're able to say, okay, then that patient needs to go here. To make you go through that whole assessment, that would be far above and beyond what is necessary and what would be helpful to you, because you're already dealing with get them out of a house, get them out of a car. You've got so many other things that you're already dealing with that take up time. We don't need you, to do that. But I would encourage you certainly to go, you can look into it, you can see about, learning it, but I wouldn't say that it's something you should be using just because you don't have the time. So, but that's a great question. Anybody else have any questions? Okay. All right. We thank you so much for attending.
Thank you.
Yes.
If providers bring somebody in to one of the treatment centers, is there access to get outcome information? How do we get?
Yeah, so all you need to do is, if providers bring patients in to LifeBridge, what I can do is I will leave my card or a few of my cards here. If you have a certain person, we have in the past put up kind of like feedback forms up in that EMS room. We had a poster board and we put up some runs, and they're Baltimore City, but it's from wherever they come from. But we've put some up in that room to give feedback. But if you have a specific person that you want to know about, if you can either give us, like the date, the time, whatever you call it, a PCR number or some identifying number that we can then follow up with you, I would be happy to provide that information for you. But we try to, give feedback. We send some outcome reports to. There's Schenning. Is it Captain Schenning or? Director Schenning, sorry. Okay, so, we send outcome, but whether it trickles down, I'm not sure. So, because I'm sure there's a lot, because they're going to all different areas. So if you specifically want to know about somebody, please just, you can contact me, and I will leave my card and my email address. And I know you also have somebody here who's maybe works at LifeBridge or Sinai, who can also who relay that information. But I'll be happy to leave. I've got a bunch of cards. I can leave them with the doctor, and you can get that information.
And I have a card too if you guys ever
Yeah, if it's a Northwest one or a Sinai one, we'll get it back to you. Okay?
Thank you.
All right.
Okay, thank you.